have to be serious now. No fun.
Dr. Nafisi, we can start.
Okay, just a minute. I'll start right away. So, good afternoon, everybody. I'm Shahriar Nafisi. I'm professor of neurology, Tehran University of Medical Sciences. I welcome you all to this webinar. It's about updates on neuromuscular disorders and updates on treatment. I would like to thank the Office of International Affairs of Tehran University of Medical Sciences for organizing this meeting, and also all the speakers, my dear colleagues from France and Iran who helped me organize this meeting. So we will have 6 talks. And we will have 2 sessions. Each session has 3 lectures and 15 minutes for questions and answers at the end. So please write down your questions in the chat box so we can address the questions after the lectures. And then we'll go to the second session. Farzad is going to moderate the second session, and then we'll have 3 lectures and another round of questions and answers afterwards. So I hope you'll enjoy this meeting, and it will be informative and fruitful for you. So I'll start with the first speaker. Our first speaker is Professor Jan Perrion. He's a neurologist, professor of physiology, head of Department of Clinical Neurophysiology and Reference Center for Neuromuscular Disorders in Nantes University Hospital. And he's going to talk about Pompe disease for 25 minutes. Jan, welcome, and you can start right now.
Salam Kemadat Hamkorone Aziz. Thank you, Shaham, for this kind invitation. Thank you, all of you in Tehran, for this invitation. And I'm going to try to give some update regarding Pompe disease. And just to start, as you know, Pompe disease is a lysosomal storage disease. This is secondary to acid maltase deficiency, also named acid alpha glucosidase. This is the same, different name for the same enzyme. And this induces some accumulation of glycogen, mainly in the muscle, skeletal muscle, cardiac muscle, but also in the liver. Indeed, this is a quite rare disease, about 1 out of 40,000 births. And this is really rare in France, although we search for it on a regular basis. And also what has to be kept in mind is that depending on the level of the remaining enzyme, you can have very severe forms with an infantile, neonatal sometimes onset. And on the other hand, you can have some much less severe forms with an onset when the patients are adults, sometimes very late in the age. And the clinical phenotype is quite different in both cases, because in the infantile form, death may occur very early in the life because of cardiomyopathy. And in the adult form, in some cases, the respiratory system and the respiratory consequences of the musculoskeletal lesions is going to be much more predominant. In both cases, we have been using, all of us have been using some treatments in order to delay all the loss of function of those patients, and which is just shortly summarized here with the effect of enzyme therapy, replacement therapy right here in the children, and with here the survival curves of the children without any treatment. And here just an illustration regarding the 6-minute walk test distance performed by the patients after treatment, but I will go back to this in a minute. So it was just to set up the whole stuff. So what about therapeutics? Therapeutics is something which has been changing a lot in the last 10, 15 years in the neuromuscular fields. And this is also the reason why you have, for instance, set up this sort of topics. And indeed, we are lucky when we are neurologists working in the field of neuromuscular diseases, because nowadays we have more and more treatments. And maybe Pompe disease was one of the first of these these diseases with new treatments. With the arrival of the enzyme, indeed, there is a lack of acid maltase enzymes, so there is a deficiency in this enzyme. And as for treatments, usually what we think of is that we can act on either the cause, mechanisms, or the consequences of the disease. Here, there is a lack of the enzyme, and so we could hope and we could try to replace this enzyme. This enzyme is a quite important one because this is one of the major parts of muscle metabolism. And here is a nice slide, a complicated slide. I'm not going to comment overall, but here you have the place. You have here only the place where the acid maltase take its role. And indeed, in the skeletal muscle fiber, this acid maltase enzyme is going to help providing back glucose from glycogen, which is a storage form in the skeletal muscle. So this is a lysosomal glycogenolysis. And indeed, when there is a lack of this enzyme, the performance of the muscle fibers is impaired and much impaired and going to a loss of function with the years. So we could think of in an easy way and say, okay, there is a lack of this enzyme. We have a possibility to replace this enzyme, and this is the so-called enzyme replacement therapy, which has been used with the drug Myozyme, just to tell his name, of course, everybody knows it. And this is something which has been done now for years. Initially, there was a huge hope of curing those patients by using this enzyme. And the fact is that the effects are quite major in very young children. But the fact is also is that there was some disappointment, I would say, in adult patients. And just to illustrate here this sort of disappointment, a recent paper which was performed under the supervision of Pascal Laforêt, who is the leader in the field in France in Garches Hospital. And here, what you can see is that if you consider adult patients treated with enzyme, ERT, let's say 4 years, initially in the first 2 years, they gain a little bit and there is no decay in the distance performed, walked in 6 minutes. This is a 6-minute walk test, okay? So that means the distance you can walk over a 6-minute period. And then what you observe is that on the long term, the curve here is going down again, which means that although you replaced the enzyme, which is lacking in the skeletal muscle fiber, this is not sufficient to help the skeletal muscle fiber to function totally normally, and there is still some decay. And indeed, this is also observed when you consider the testing, the more formal testing using the MFM battery with a lot of tests, and all of them are concordant in the fact that this is not sufficient, and this is there is a lack of effect of the drug. So what you could say is that maybe this enzyme is useful for a couple of years in adults, and then it's not useful, so maybe we should stop as it's not so useful. Indeed, this is not the case, and I would just to present you here a paper by our colleagues from Bern, where they, indeed, in a few years ago, there was no way to get Myozyme for several months in Switzerland. And so they had patients who had been treating for several years, then had to stop, and then they came back to the enzyme. And so what they observed is that when those patients stopped the treatment, they were going much worse. And so, indeed, in the long term, the enzyme is not sufficient to stabilize the patient, but if you stop it, they are getting worse. So they still need it. So there are two messages from those papers. One of the messages is related to the ERT, which is not panacea. The second one is that you still need it. And the fact is that this is a lifelong treatment, requiring infusions, requiring a lot of money too, because this is quite expensive still, as most of the treatments in the field of rare disease. And the fact also is that there is various effectiveness from patient to patient and from tissue to tissue. Indeed, it's more efficient in young patients, in early onset Pompe disease patients than in late onset Pompe disease patients. And it's more efficient on cardiac muscle rather than on skeletal muscle, which is indeed the one which is more involved in adult patients. Another point is that you may develop some neutralizing anti-RH-GAA antibodies. And so this might be also a reason for the lack of efficiency of the enzyme. And finally, two other points. The fact is that the enzyme is not able to cross the blood-brain barrier. And so this is ineffective to counteract the deleterious effects of the lack of enzyme in the central nervous system. And also in muscle, there are plenty of consequences due to the lack of enzyme, including autophagy defects, and this may increase the resistance to the ERT. So we have the ERT since about 15 years, maybe something like that, but this is not enough. So what else? What else could we have? And so what I'm going to try to show now is that there are several directions where we could go, and all these directions can be complementary, each one to the other. And first of all, we could try to improve the ERT. And the fact is that there are some possibilities that may help to facilitate the tissue uptake of the enzyme, and changing just one little part of the composition of the enzyme, and for instance, in increasing mannose-6-phosphate levels in the enzyme, this helps the tissue uptake of the enzyme. And the fact is that this is something which has been developed by the company who is producing Myozyme. And so this is a so-called treatment aval-glucosidase alpha, the NeoGA. And NeoGA is an assessment, and indeed the assessment is just recently finished, but as far as I know, not yet published. And the information you now have on the screen comes from Sanofi website, where you can see, oops, sorry, excuse me, just a minute, where you can see part of the result. And so in this work, they compared the classical therapy, which is Myozyme, to the new one, the NeoGAA. with the conclusion that the Neo-GAA is better, the effects are better, and there is a major improvement, larger improvement at least, on, for instance, the person predicted forced vital capacity when they compare the patients treated by Neo-GAA or classical therapy. The fact is that this is not reaching statistical significance for superiority, but this is also seen when they compared the distance performed in 6 minutes, so at the 6-minute walk test distance, with an increase of 30 meters for 60 minutes. And always we have the same problems in all the new treatments, and specifically, for instance, in Duchenne disease, which is what is the clinical significance of being able to walk 30 meters in addition to what you could be without a treatment? Is it really significant? Is it worth to take a drug for that? So this is a point here for this Neo-GAA. There is also a similar study, Baby Comet, which is ongoing for children patients, and I guess we'll have very, very soon some more information regarding the results of these studies. Another way to improve the ERT would be to use chaperone therapy. And in that case, you use additional drugs, which are small enzyme inhibitors, which are going to interact with the mutated protein. And this is helping proper folding, or this is increasing the stability of the protein, and it's transit into the cell. And so one of the advantages of this drug is that it's just easy to take, it's porous, it can cross BBB, the blood-brain barrier, high bioavailability. 2 drugs, as far as I know, have been proposed for that. Duvoglustat, which has been shown to be helpful for reinstating the correct trafficking, the maturation, or the activity of GAA in a murine model. And the other one is miglustat with some sort of similar effects. Here, just to show you a paper which is not so recent, actually, because it was published already 4 years ago. But here, on this model, they demonstrated that the total activity, the GAA activity in plasma was increased in all Pompe patients. And also, this was demonstrated also with biopsy specimens. So this is something which could be also helpful, and which is coming in the upcoming, which is coming very soon, very likely on the market. So next step would be maybe the more interesting one, which is to restore GAA production. So one tool is to replace the enzyme which is lacking, which is not produced by the skeletal muscle fiber, for instance, but another way is to help the body to produce this GAA. And so here for restoring GAA production, one way would be to act on the expression of the gene, not really on the DNA, but on the RNA. And the fact is that this is something which has been already tried for Duchenne muscular dystrophy with the Ataluren translearner that you know, of course, which allows the cell to read through stop codon, abnormal stop codon right here, for instance, and to facilitate the production of the protein. So this could be interesting because many causative mutations of Pompe disease are stop codon, but in this actually right now there is no evidence. So this was a statement from a paper published 2 years ago, no evidence showing the effectiveness of such an option in Pompe disease. The fact is that Ataluren is widely used nowadays for Duchenne patients, and I'm sure that it will be said a little bit later today, with, again, some sort of disappointing effects, still working, but not as much as it would be hoped. Another way to act on gene expression therapy, so again on RNA, not yet on DNA, would be to use antisense oligonucleotide acting on different manners. And here again, that's something which can be interesting because of the sort of mutation which are encountered in Pompe disease. And excuse me, by using antisense oligonucleotides, this may be helpful in order to restore some misregulation, some splicing misregulation in some specific mutations. The fact again is that in this case, in these very specific cases, for stop codon therapy or for this one, it depends on the specific mutation which is affecting the patient. So it's necessarily restricted to a low number of patients. And I remember you, Pompe disease is quite rare. So the most exciting point would be, of course, gene therapy. And for gene therapy, in that case, you act on DNA, you want to introduce the functional gene into the body. And so this is something which is performed using viruses, and not coronaviruses, but adenovirus-associated vectors, AAV mainly, or lentiviral ones. This is something which is working on SMA, Spinal Muscular Atrophy, and it's with a spectacular results. This is something which is ongoing in Duchenne with mini-dystrophin. Again, this will be said later today. But the fact is, this is something also a goal for Pompe disease. And so far, experimental studies on mice, quails, or on primates models have provided encouraging results. And what has been shown is that by using this gene therapy, you can obtain an increased GA activity in various tissues. You can observe a decreased glycogen content, which is positive in here. And so you can also imagine that you are going to improve the patient and not only changing the level of the enzyme in the body. As you can see, this is something which is ongoing with more and more references of papers in animals. And what has been shown, for instance, is that in murine models, AAV gene therapy has been capable of inducing robust transgene expression in the heart mainly, the diaphragm too. The fact is that some people tried to introduce more specifically the gene therapy into the diaphragm because they want to have a higher expression of the gene right in this muscle. And if you use a systematic delivery, it may be more difficult to reach this level. And also, this was also performed by using intrathecal administration. And here is an example in an older paper where the intrathecal administration of gene therapy with AAV9 was able of providing neurological improvement in the model a few months after the treatment, and which was something which was lasting with the months. So something which is upcoming, here just a screen copy of Neonatal website, just to show you that very recently there was a launch of gene therapy clinical trial in patients. And you see here it is just stated that the first study participant was dosed in the USA. And that was February, that means just 3 months ago. So this is something which is upcoming. Gene therapy, and of course, everybody has a lot of excitation about this new therapy. Last part is other targets. And so far, I talked about acting on the mechanism. There is a lack of enzyme, we replace the enzyme. A lack of gene abnormality, we act on the cause, we provide it, and we use gene therapy. But we can also consider the consequences of the lack of enzyme. And so these are the other targets. And for instance, what could be proposed, what could be aimed also is to try to modulate skeletal muscle pathophysiology by acting on autophagy in these patients. And this is something which has been proposed here by acting on the transcription factor EB, which can be a therapeutic target for this Pompe disease. And in this, with the aim of reducing the autophagy. And this is something which can be used by acting on this enzyme, but this is not the only way to do it. I'm just going to this slide. And for instance, here in my place in Nantes, we have a research team working on Pompe disease. And what they want to do is to act on autophagy. And for instance, one of their targets would be FOXO3A, which is also implicated in autophagy induction, which is also acting very similarly to TFEB. And so this is another target which can be considered in order to reduce some of the consequences of the lack of enzyme in the skeletal muscle in Pompe disease in order to reduce autophagy process. In the same way, something which could be done also would be to act on satellite cells. And the fact is that when you consider what happens in skeletal muscle, you have some glycogen overload from the beginning. You have degeneration and regeneration, which is also contributing to the process, clearly not as marked as it can be in some other muscle dystrophies, but still present. And this induces some structural damages on the long term. And the fact is that in Pompe disease, the pool of satellite cells remains intact and there is no cell pool depletion. Of course, on the other hand, if you consider, for instance, Duchenne muscular dystrophy, the satellite cells try to do their best for regeneration, but after 3, 4 years, 5 years, there is a lack of those satellite cells, and this contributes to the fibrosis, which is and the necrosis, which is ongoing in Duchenne patients. What was shown 5 years ago, 6 years ago in Pompe disease is that there is no lack of satellite cells, but there is a lack of activating signal, and indeed the activation. So the satellite cells are less activated in Pompe disease as compared to what they should do. And so the team in Nantes is working here in trying to identify some markers, some factors that could contribute to improve that and trying to decipher the reasons why there is no activation of satellite cells. So again, this is here an example of what could be done in order to reduce part of the consequences of the lack of enzyme in a skeletal muscle fiber in Pompe disease. And finally, also, Pompe disease is not only a properly skeletal muscle disease, but it has also a central nervous system, a neural part. And so this is something which has also to be explored, indeed. And the fact is that it was shown that there are some troubles regarding the neuromuscular junction in those Pompe disease patients. And this is something here which is illustrated by the efficacy of 3,4-diaminopyridine phosphate on neuromuscular junction in Pompe disease. But this is here in zebrafish model. And here, in these very recent papers, those guys, they just demonstrated an improvement of the neuromuscular junction function in this zebrafish after administration of 3,4-DAPP. And so this is also another possible target for Pompe disease. And indeed, just to conclude, I was just saying what else could be used more than just ERT in Pompe disease, but actually I guess we will have in the upcoming years plenty of different drugs acting together in order to help the patient in the same way as when you drink coffee, whether this is in Tehran or in Iran or in France or wherever you want, you now have plenty of coffee, and this is a good thing for all of us. And so I just would say, Baroye Davat, And en français, merci pour votre attention. And here are two pictures of my place in Nantes. And I really thank you for your attention.
Okay, thank you, Jan, for this fantastic presentation. So please write down your questions regarding Jan's lecture. We'll come back to the question and answers later on. So I'm the next speaker. I'm going to talk about updates on Myasthenia Gravis. So I hope you see my screen.
Yes.
Is it okay?
Yeah, that's okay.
Okay, so this is disclosure, and so this is a paper from several years ago, and you can see the course of myasthenia gravis over time. So although mortality has declined, but still there is significant morbidity, and more patients have improved in the past decades, but many remain unchanged or worse. And although more patients are in better condition right now, and death has reduced and mortality has reduced, but remission has almost unchanged over many years. So you still see many patients which don't reach complete stable remission. And this is the history of myasthenia gravis treatment from the beginning, when the first drug physostigmine was introduced, and then thymectomy, and different immunosuppressives like corticosteroids and other immunosuppressives, IVIG, and then plasma exchange, rituximab, and finally eculizumab, and now we have new treatments in the pipeline. So this is another slide that shows the reduction in mortality and different medications that have came to us and we can use for the treatment of myasthenia gravis. So these are the medications and the treatments that are currently available. We use symptomatic therapy, IVIG, plasma exchange, thymectomy, corticosteroids, different immunosuppressives, and also monoclonal antibodies. But these are not enough. And why do we need new treatments? Because, as I already mentioned, current treatments have multiple unwanted side effects, and this is mainly due to the widespread action of the drugs, and also a large subset of patients fail to have meaningful response. Many patients respond but are left with major disabilities, or you cannot wean the medications. So from Now on, I'm going to talk about recent advances in therapy. I'm going to leave the routine behind and talk a little bit about new medications and new available options. So first, I'm going to say a few points about thymectomy. Subcutaneous immunoglobulins are now available and are used in different autoimmune neuromuscular disorders. We don't have it right now in Iran, but I hope it will become available soon. And then we have a few groups of new medications. The first is neonatal FC receptor inhibitors. The second one, complement inhibitors. And then we have the B-cell depleting monoclonal antibodies, acetylcholine mimetic peptides, CAR T-cell therapy, and finally, stem cell therapy. So I'm going to skip this slide. About thymectomy, in 2016, the results of the MGTX trial was published in New England Journal of Medicine, and it showed that patients who underwent thymectomy had an overall better of prednisone was reduced, and they required less immunosuppression in addition to prednisone, and there were less hospitalization for exacerbations. And this was a 2-year extension. The first trial was for 3 years, and with this 2-year extension, there was a 5-year follow-up. So as you see, the benefit continues. And after 5 years, still the patients who have received thymectomy are doing better than patients who haven't had thymectomy. And this is the most recent publication from this trial. It was published a few months ago in Green Journal. And as you see in this slide, patients who had thymectomy had more frequent complete withdrawal of prednisone. So 64% of patients who had thymectomy reached the point that they were not taking any prednisone. And on the other hand, the placebo group or the group with only prednisone had this chance for 38%. And this complete stable remission was achieved earlier than the other group. So a new group of medications that I'm going to talk about are the neonatal FC receptor inhibitors. So neonatal FC receptor, as you see in the in this picture, is responsible for recycling IgG. So when IgG is recycled, the IgG clearance is reduced, because when the IgG is bound to the receptor, it's not degraded and it goes back to the circulation. But when there's a block of this neonatal FC receptor, IgGs are not bound, and the IgGs that are not bound are degraded in the lysosomes. So when you block this FcRn receptor, you increase IgG clearance. So it's a sort of chemical plasma exchange. And in the past few years, there have been great development in this area, and several agents are now in clinical trial that I'm going to mention briefly. The first one is efgartigimod, and as you see, the phase 2 study has been completed. It was published in 2019, and it's an intravenous administration. And in different scales, you see that patients who received efgartigimod had much better outcome than patients on usual care. And the phase 3 study is ongoing. I'm going to show you the results that I have available from this phase 3 studies, although it's not published yet. And there are also trials going on in children and for the subcutaneous formulation of this medications, because IV administration is a major limitation. And if you can give the medication subcutaneously, it can be self-administered. So it's a great advantage. So the next few slides are from the ADAPT study, the phase 3 study of efgartigimod that I have borrowed from Dr. Howard that has presented the results a few months ago. So as you see, the level of IgG and acetylcholine receptor antibody have a meaningful drop after receiving efgartigimod. And the drop in IgG is in all different subtypes of IgG, even IgG4. So it will be effective even in MuSK-positive myasthenic patients. It's not only the acetylcholine receptor antibody-positive patients. And regarding the clinical data, as you see, the MG-ADL was used, and the quantitative MG score was used and as primary and secondary endpoints. And there was significant improvement in the patients who received efgartigimod, and in the patients who were responders, the effect came on in 84% of the patients in the first 2 weeks. And this is the duration of response after the injection of IV efgartigimod. As you see, some patients even have a response for more than 12 weeks. And then they have to repeat the cycle of treatment. Another medication in this group is Ravolizumab. It's a monoclonal antibody against neonatal FC receptor. The phase 2 results are already published. It's weekly subcutaneous infusion. And this phase 2 trial is mainly about safety. The data on efficacy were not, because of the low number of the patients, was not enough to be interpreted. But the phase 3 trial has just recently started. This paper, the phase 2 trial, was published in Neurology just a few months ago. Another medication in this group is nipocalimab, and you can see the results of the phase 2 study of this medication. It was called Vivacity. It's not published, but the results was presented in American Academy meeting, the virtual meeting this year, last month. And as you can see, there was both clinical and serologic response in patients who received nipocalimab. So the next group that I'm going to talk about is complement inhibitors. As you can see, the normal neuromuscular junction in the upper panel, and what happens in acetylcholine receptor positive myasthenia gravis, which is complement mediated. You can see in the bottom panel. And as you see, the membrane attack complexes are formed and damage the postsynaptic membrane and cause a significant muscle weakness. So for this reason, different medications that can block the activation of complement has been introduced. Some are FDA approved, some are now in the clinical trial. The first drug in this list is eculizumab. The phase 3 study was called REGAIN. It was published in Lancet Neurology in 2017. Patients included were non-thymomatous generalized myasthenic patients with acetylcholine receptor antibody positivity and MGFA class 2 to 4. All the patients received vaccination against Neisseria meningitis, and the background medications have to be stable for the past few weeks before starting the medication. And I'm going to show you the results. As you see, after 26 weeks, different scales that were used, MG-ADL, QMG, MG composite score, MG-QOL, all showed significant benefit compared to the placebo group. And this was continued. An open label extension study was performed. And as you see, all the patients in the placebo group were switched to eculizumab. And as you see here, the benefit continued. It was like 103 weeks, 130 weeks follow-up. And as you see, the benefit of eculizumab is still present. The dosing, you can see it's 900 milligrams for the first 4 weeks, and then 1200 milligrams every 2 weeks thereafter. So this is the main drawback of the medication. It's IV administration, and now they're working on the subcutaneous formulation. FDA approved the drug in October 2017, and EMA also approved in the same year. There's a phase 3 trial in pediatric refractory MG that is ongoing, and there was a case series of 3 refractory cases which received eculizumab when they were ventilator dependent, and all 3 patients showed improvement. So it's not just MGFA class 2 to 4. It can also be used in ventilator dependent and refractory patients. The new drug in this category is Ravolizumab. As you see, this is a new generation of the previous medication, and it's developed by the same company, Alexion Pharmaceuticals, and the first global approval was for PNH in December 2018. It's administered IV, but it's every 8 weeks, and the clinical development of subcutaneous formulation is underway. And phase 3 trial is ongoing right now. The other medication is zilucoplan, and this is also another peptide. It's not a monoclonal antibody. It's a peptide that inhibits complement 5. And as you see, when it inhibits complement 5, it can prevent the development of membrane attack complexes and prevent the damage to the postsynaptic membrane. So phase 2 trial of zilucoplan has been published in JAMA Neurology last year, and it was effective. So they started the phase 3 trial. It's recruiting, and it has started right now. So the next group is the B-cell depleting monoclonal antibodies. In this group, we have rituximab available. It's a anti-CD20 monoclonal antibody. We also have ocrelizumab in Iran, and another medication that is under development is the anti-CD19 monoclonal antibody, inebilizumab, that is already has approval, FDA approval for NMOSD, but it's being trialed for myasthenia gravis also. So for rituximab, I'm going to pass these slides because of the lack of time, and I'm just going to show you our experience. There are many biosimilars of rituximab in the world. We have Zitox. The bottom line you see, it's developed by Ariogen Biopharma, and we have had this medication for many years in Iran. It works very good. I haven't seen any difference between this and Maptera. We also had an open label trial with our colleagues in Iran for Zitox in refractory myasthenia gravis patients that didn't respond to prednisone plus another immunosuppressive agent. And we followed the patients for 48 weeks. It was a multi-center study. 36 patients participated, and we had a reduction in different scales like myasthenia gravis composite score, ADL and QOL, and both the dosage of prednisone and pyridostigmine had a significant reduction after the study period. This is the CD19 medication that I already told you. It's called Uplizna. It's already approved for in June 2020 for NMOSD, and the phase 3 trial for generalized myasthenia has just started, so we don't have the results yet. This is another innovative medication. It's called acetylcholine receptor mimetic peptide, Myasthenia or Myasthenia, and you can see the phase 1 trial. It's a peptide, has two components. One is the B peptide, the other one is the T peptide, and it's designed so that it can desensitize against the autoimmunity and the autoimmune process that has begun in myasthenic patients. The phase 1 demonstrated safety and immunogenicity, and also you can see that there was some improvement in the patients. They are going to start the phase 2-3 trial, but it's still not started yet. I have a few remaining slides. One is about CAR T-cell therapy. As you know, CAR T-cell therapy has approval for different malignancies, but they are working on application of this kind of therapy in autoimmune disease and viral infections like HIV and hepatitis B and C. And just a few words about CAR T-cell therapy. They separate the own patient's T cells, and then they insert the CAR gene into the T cell genome, and the CAR T cell is expanded in vitro and then infused back into the patient. So it has to be designed individually for different targets. For instance, for each malignancy, there is a specific antigenic target that it's designed for that. And for autoimmune disease also, you have to do the same. And these are the list of different disease conditions that are being trialed with CAR T-cell therapy. As you see, generalized myasthenia gravis, pemphigus, lupus, NMOSD, HIV infection, and even COVID are being trialed. All are in phase 1 or 2 trial. And for myasthenia gravis, the phase 1 and phase 2 trial is underway, and we should wait for the results. It's a very promising type of therapy that hopefully will be available in a few years. And this is the last thing I'm going to talk about. It's autologous hematopoietic stem cell therapy. This is a publication in 2016. The study was done on 7 refractory myasthenia gravis patients. 5 of them were acetylcholine receptor antibody positive, and they all received autologous hematopoietic stem cell therapy. And all the patients are in complete stable remission, don't have any residual symptoms, and are free of any medication. And the adverse events were minor, nothing serious. One patient developed autoimmune megakaryocytic thrombocytopenia that was appropriately treated. So thank you for your attention. I'm going to stop right now, and I'm going to introduce the next speaker. The next speaker, who many of you already know, he has been to Iran several times in the past few years for different congresses, and has a very good collaboration with us in Iran. Professor Shahram Attarian, he's head of the Neuromuscular Disease and ALS department at Aix-Marseille University, and he's also a coordinator of the French Neuromuscular Disease Network. Shahram will come back to Iran virtually. Shahram is going to talk about recent updates in therapeutics of hereditary neuropathies and familial amyloid polyneuropathy. This is a very interesting field, and there has been an explosion of different trials and medication in this field. We're going to hear from Shahram about these advances. Thank you.
Thank you very much. I would thank Professor Nafisi and Dr. Fateh for the organization of this wonderful meeting. I'm very happy to be with you. Of course, it would be better to be with you in Tehran, in Iran, but hopefully very soon, very soon. I don't know if you see my screen.
Yes, that's okay.
Yeah.
Okay. And thank you to Tehran University for allowing the organization of the meeting. So my first part of our talk is about familial amyloid polyneuropathy, FAP. Why it is crucial to diagnose FAP, because now there are 2 wonderful medications are available. The first one is patisiran, which is a small RNA, and the second one is inotersen, which is a antisense oligonucleotide. FAP is a severe hereditary neuropathy of adult onset affecting the sensorimotor and autonomic function, as well as other organs such as heart, eyes, and kidney. Evolution is fatal without treatment, and before 1919s, it was considered as a neuropathy of early onset under 50 years. It's often diagnosed in the setting of sporadic late onset over 50 years disabling neuropathy with various phenotypes. So availability of genetic testing has improved diagnosis in non-endemic countries. In France, we can detect the neuropathy everywhere. It's widespread, and this is the case in all over the world. There are endemic countries, regions such as Portugal, Sweden, and Japan, but many other countries, in many other regions, we can find the patients can be detected. Recently, this FAP patient had been reported in Turkey, and I believe that the cases, many cases of are in Iran. Of course, these neuropathy are very rare. The frequency is 1 out of 200,000 or to 500,000, but more than 1,000 patients can be detected in a country such as Iran. Of course, you know, early onset form, but what is difficult is late onset form of FAP. The majority of cases in France, about 75% of the cases reporting is late, and there is no family history which make the diagnosis difficult. We will see that the diagnosis is difficult and delayed, or on average by 3 years after the first manifestations, and the clinical picture in this late form differs from the early onset form by the sensorimotor nature of the deficit, the achievement of also sensory modalities, in particular proprioceptive modality. The more exception nature of dysautonomy, which is found in 10 to 15% of the cases in this form, and the more often painful nature of the neuropathy. More atypical presentation can be seen, neuropathy beginning in the upper limbs, ataxic form, and even motor neuropathy. In France, about 25% of cases have ataxic forms, and some of them begin at the upper limbs, which is not usual. Therefore, diagnosis is usually there, as I told you, delayed by 2 to 5 years in countries such as France. This favored by sporadic presentation, many pitfall and misdiagnosis because of varied inaugural symptoms. CIDP is one of the major misdiagnoses because, as I told you, sensory motor impairment with areflexia, nerve conduction for feeling, FNSP definite criteria for CIDP in many cases, and also albuminocytologic dissociation in CSF, again in frequently in these patients. Other misdiagnoses are recurrent, including lumbar spinal stenosis. This is very interesting. In many cases, the disease begin with the lumbar spinal stenosis, such as carpal tunnel syndromes, and of course, idiopathic axonal polyneuropathy and cerebral motor neuron disease. So FAP is rarely initially suspected in late onset form, and in expert center in France, only in 20 to 30% of the cases are diagnosis at first shot. Tafamidis, which is a stabilizer of TTR, is available since 2013 in Europe. It slows down the disease, but the disease continues to progress. We give it in France at the very early stage of the disease. But the new medication, as I told you, is patisiran and inotersen. First, patisiran, which is a small RNAe, which impact the traduction of TTR and slow down it clearly, about 80% in treated group of patients in comparison to placebo group. And of course, the efficiency is wonderful. The clinical benefit is very, very significant. As we can see in placebo group, the pathology is slow, evolve and progress, whereas in treated group, patient treated by patisiran, the pathology stop to progress, even they are improved. And this for all outcome measures written in this study. Very recently, in 2020, we published the lead is David Adams, which is in Paris, published the effect of the efficiency of open label extension of this medication. As you can see, the patient remained stable in treated group, and in patients who were in placebo group during the trial, when the treatment is given, they stop to evolve, even they are improved. And again, this pattern for all of outcome measures. The second wonderful medication is inotersen, which is an antisense antinucleotide. Again, very, very significantly positive. Patients, the progression of disease is clearly slowed down, but perhaps a little less than patisiran, but very clearly is slowed down in comparison to placebo group. And again, this wonderful effect for all of outcome measures. But inotersen really have some severe adverse events, which are thrombocytopenia and renal events in very few patients. But we have to monitor this patient very closely, and that's why in France, inotersen is used in second time after failure of patisiran, or if patient is not responder to patisiran. And again, the data from data on long-term efficacy of inotersen have been very recently published, and again, it confirms that the progression of the disease is clearly slowed down. As you can see, the patient progress was clearly very less than placebo group, significantly less than placebo group. And when the patients who were treated in group placebo group are treated by Unituxin, the disease clearly slows down. We have now a good biomarker in this disease, which is neurofilament light chain. As you can see here, the level of serum NFL is clearly increased in patients in comparison to controls. And under treatment, you can see that by patisiran, in this case, the level of NFL decreased clearly over time, and after that remains stable in comparison to placebo group. Therefore, we can monitor the disease progression and response to treatment by, in addition to clinical scores, by NFL. The second part of my talk is about late onset riboflavin transporter deficiency, which is a treatable mimic of motor neuropathy, hereditary motor neuropathy. This neuropathy, this etiology was described at the end of 18th century, and 10 years in 2010, the two mutations have been reported. Now we have again serum biomarker, which is riboflavin level, and the diagnosis can be also done by abnormal profile of acetylcarnitine. This pathology have been reported as to be mainly pediatric, but more and more adult are reported. A group of Paris has reported 25 patients presenting four type. The majority of cases, half of the cases had motor neuropathy or distal hereditary motor neuropathy, but some of them had very acute or subacute form mimicking Guillain-Barré syndrome or AMAN. Please be careful if you have axonal neuropathy, predominantly motor neuropathy, who are associated with deafness, cranial pair involvement, axial affection, or respiratory impairment. Please think about this etiology, because this is a treatable etiology. You can give them riboflavin and improve these patients. How about Charcot-Marie-Tooth? Charcot-Marie-Tooth, which is the most common rare neuromuscular disease, and there are about 30,000 people with Charcot-Marie-Tooth identified in France. Now we have more than 120 genes identified. So this is a very interesting paper published in Nature Genetics in 2020, and the author reported SORD mutation in many patients with CMT2, which is autosomic recessive. And again, these patients had very predominant motor neuropathy. So they have studied about 1,000 patients, undiagnosed patients with autosomic recessive form, and 41 patients had this mutation. Therefore, estimated prevalence was calculated to be 1 out of 100,000, which is the prevalence of Guillain-Barré syndrome or CIDP. And the majority of these cases, as I told you, were sporadic, and they had predominantly sensory motor form, but predominantly motor weakness or distal hereditary motor neuropathy. The age of onset concern this neuropathy concern the young adults, but patients up to 40 years old have been identified. The severity is moderate, and what is very, very interesting is that you can, again, there is a steric biomarker, which is sorbitol, which is increased up to 100 times and it can be easily measured. And what is very, very interesting that there are treatments for potential treatment for this CMT. There are aldolase reductase inhibitors, which are actually available for in diabetes. So the mutation concern this enzyme sorbitol, the dehydrogenase, therefore the level of sorbitol increase in cell as seen as shown here in mutated animal in comparison to control, or in serum of mutated animal in comparison to control. And as I told you, what is interesting is the availability of treatments. Here, when measuring intracellular level of sorbitol, you can see increased level of it, and when these mutated animal are treated by these two medications, the level of sorbitol return back to the level of the control. And it's very interesting, even in the brain of animals, you can see that the level of the sorbitol go back to normal level, near normal level in comparison to not treated animals. Even in when you measure the level of activity of flies, the Drosophila flies, for example, older flies, you can see that treated flies are clearly improved in comparison to not treated animal, and the level return back to near normal in these animals. So very interesting treatment potential. The trial will begin in United States and Europe. We have beginning to detect these patients, which are not very rare, and can be diagnosed very easily by the measure of sorbitol. How about the other CMT, especially CMT1A? The first molecule that I would like to talk about is PXT 3003, which has several, many of you know it. Pharynx has found this mixture of naltrexone, baclofen, and sorbitol by virtual screening and so on, and use it at very low doses. But the mixture is very efficient because each of these molecules act at this different level of production of PMP22 and decrease the level of PMP22. Each of these molecules have some effect on in vitro or in vivo when you measure functional tests, but some of action of these three medications is purely significant and potentialized in vitro and in vivo for example, grip tests. So the rationale was provided to do clinical trial that was performed first in France in 2012. 80 patients were included in this study, and finally we found that the higher dose was a little bit improved the patients in comparison to placebo. So the difference was clearly significant. So we moved on a phase 3, international phase 3 multicenter randomized double-blind placebo-controlled study, including 323 patients testing 2 doses, which were the most interesting doses, and found again that the medication improved mildly, but improved patients under treatment after 15 months of treatment in comparison to placebo group. It was the case for principal outcome measure and for an interesting outcome measure, which was 10-meter walk time. Again, the higher dose was clearly had clearly significant benefit in comparison to placebo. Now we are going to start in a few days second phase 3, international phase 3, to confirm these findings. So which are the other therapeutic trials? As I told you, there are 2 medications who have been tested in human. Beside PXD 3003, only Cephin-1 has been tested. We have tested in normal subject. This is an anti-hypertension medication, which is very interesting in CMT1B. It has published the efficacy of Cephin-1 was published in Science in 2015 in animal models. As I told you, we have tested in normal subject to know the toxicity of this medication, and we are going to test it at the beginning of 2022 in CMT1B and CMT1A. The other molecule are tested only in animals, and we are waiting for confirmation as Jan told you about the antisense oligonucleotide in Pompe diseases. These methods also are used in CMT1A or a small RNA as amyloid neuropathies, but or gene therapy, which is a very interesting method reported by very recently, few days ago, by a group of Montpellier in south of France, using gene therapy, gene replacement by PMP22 in animal model. But the problem with this method is that the decrease of PMP22 is too much, it's not controlled, and the patient with CMT1A are transformed to the animals with CMT1A are transformed to HNPP. A very interesting method may be gene therapy by neurotrophin 3, which is a neurotrophic factor, and improved remyelination and axon regeneration. A phase 1 has been running, and the results are very encouraging, and we're waiting for phase 2. In another very interesting drug in CMT, which is tested in animals, is metaphysin agonist for CMT2A. This drug, the result of this drug have been published in Science in 2018. A phase 2 is a program to start in near future in Europe and the United States. These results in these molecules in CMTX is the results of studies in vitro. So we have to wait to see what happened with this molecule later. In terms of, just before finishing, in terms of biomarkers, which is very interesting, it seems to be muscle MRI, quantitative muscle MRI. It will be the major secondary outcome, and can be used in clinical trial as a go-no-go biomarker. If quickly the MRI, the level of fat fraction is improved, the study can be continued. If not, the study would be stopped. This is we can measure the volume of muscle or the level of fat fraction at the level of thigh or calf in comparison to patients with CMT1A. As you can see, muscle is very clearly you can see atrophy of muscle and measure it in comparison to healthy controls, and we have very significant correlation. This was the result of our group in Marseille. We have very clear significant correlations with clinical scale and scores. Another interesting biomarker can be, which we have published recently, is the volume of nerve and other parameter of MRI of the sciatic nerve at the level of lower limbs. In this example, at the level of thigh, as you can see, the volume of sciatic nerve in patient with CMT1A is clearly increased. The hypertrophy of the nerve, and it can be quantified. We are going to do a longitudinal study to see the interest of this disease, this method for clinical trials. Again, there are very good correlation with clinical scores. To conclude, as it said before, nowadays is a wonderful period for neuromuscular disorders in hereditary neuropathies. Many molecules are available or are going to be available. Many new molecules will be tested very soon in near futures, and we have many nice biomarker for following the patients or measuring the progression of disease or impact of treatment on the patients. I hope that very soon we can have the drugs. So thank you very much for your attention.
Thank you, Shahram, for this wonderful talk. Very informative and very new, innovative treatments for hereditary neuropathies. So we have a few minutes for questions. I'm going to start with Jan. There's a question about small fiber neuropathy in Pompe disease. Do you have any experience?
To be honest, no, in the sense that I never searched for it in such Pompe disease. As far as I know, there are very few reports about it, and this is not something so prominent. The fact also is that basically small fiber neuropathy is something quite rare, maybe not so that much rare in the general population, and Pompe disease is rare too. So if there is any, I would say if there were any specific or significant small fiber neuropathy, I think we should be aware about it, but still on the other hand, and that was an example with my last slide, sometimes we get focused on a specific disorder, which is muscle, for instance, in Pompe disease, and we may miss some other involvement, such as neuromuscular junction. That was the case for the last slide, but maybe also for the small fibers. So I would say next time I will be a little bit more aware about that and check the small fibers. So just as a reminder, of course, there is questioning the patient about pain, hot sensation in the head and feet, but also some very easy test which can be used by using a basic EMG machine, which is a sympathetic skin response, so quite easy to use and to test the small fibers. And the same thing for the R interval, the heart frequency during inspiration and expiration. So this is something that can be used everywhere with simple EMG systems, and so do not hesitate to test it if you have such Pompe patients.
Shahryar, and Jan, we have published 2 cases of this patient with small fiber neuropathy, which for several years they were diagnosed as fibromyalgia, and as Jan said, autonomic test can detect it. All of them, as the best of my knowledge, all the cases who have been reported have hypercalcemia. So a small fiber neuropathy associated with hypercalcemia, Pompe disease should be tested.
Okay, great. I have a question for Jan. One of the problems that we have with current treatment of Pompe is that Myozyme doesn't enter the or pass blood-brain barrier. So infantile cases that are treated with enzyme replacement therapy gradually develop some kind of brain abnormality, white matter changes, and mental change. Do you think the new generation enzyme replacement therapy or the gene therapy will overcome this issue and will solve this problem?
Very likely the chaperone therapy concomitant to ERT might help to go through this problem. One point, the NeoJ, I'm not sure about that for the NeoJ. But for gene therapy, yes, indeed. And of course, this is something which can be hoped in the sense, if I just take the example of SMA, for instance. So SMA, this is SMN gene therapy. This is systemic delivery, and still this is aiming to target the central nervous system. So AAV9 can be a good virus, but indeed with some toxicity, which can also has to be considered, and this is the case now with SMA patients. So I would say yes for gene therapy.
Okay. One of my colleagues has asked the question about a lady with anti-MuSK positive MG. She didn't have a good response to prednisolone in combination with mycophenolate mofetil, and she was planning to start rituximab, but when she measured immunoglobulin levels, IgG and IgM levels were very low, and she's asking what we should do next. I think there's a problem giving rituximab to this patient because IgG and IgM are already very low, but she also asked if this patient can get COVID vaccine. I think she can, but probably the efficacy of the vaccine is lower than usual. My recommendation is to start another immunosuppressive like azathioprine. I don't know if other colleagues agree on this suggestion or not. Shahram, Jan, do you have any suggestions for this lady?
I guess that regarding COVID vaccine, I have the same feeling as you have. So the vaccine might be less efficient, and maybe she will need 2 shots with some distance in between in order to get covered. Regarding the treatment, she's a typical patient which is complicated for decisions, and so she did not have so far. I guess yes, she did not have so far azathioprine. And right,
Yes, yeah.
just trying to see, and that could be something needed to be tested, of course. Rituximab is still a good drug now on. How old? She's a young lady.
She is.
Rituximab is. Yeah, but she's young. But
rituximab is low level of IgG and IgM.
Rituximab is efficient. Is more efficient in MuSK, Myasthenia Gravis, and the classical one. And we published last year a paper on this field from all the patients in the west area of France undergoing rituximab and having Myasthenia Gravis. Might be another option.
And you're not worried about low level of IgG?
This was done after the plasma exchanges, I guess.
Oh, maybe, yes.
So in general, when we have many good immunosuppressor tested and the failure very, very rarely, now we can use the eculizumab.
Okay, but we don't have eculizumab right now in Iran. Although a biosimilar of eculizumab is manufactured by one of the local drug companies, but it's not available in the market right now. And the patient is MuSK positive, so eculizumab is probably...
no, the complement, yes. There's the second generation of rituximab now available, but no, Jan responded to that. No, normally such a possibility after that to use perhaps cyclosporine and
or azathioprine.
Yes.
One more.
Sorry. We use first isotropine and Celcept, and after that, if in general rituximab, and if again failure of treatment, cyclosporine, and if not, ecrorίζumab. These are the things that.
Okay, great. So I think you should measure the level of IgG and IgM after 1 month to see if it comes back to normal, and maybe at that time she can start azathioprine or even rituximab. One more question is about the trial of antisense oligos for myasthenia gravis. I haven't heard of use of antisense oligos for myasthenia gravis, and I don't find the logic for it. Jan, Shahram, do you?
No, not acquired.
I would expect this for congenital myasthenic syndrome in case of
yes, probably
rather than myasthenia gravis.
And a question about subcutaneous immunoglobulin in MG. There are several trials going on, and we have the results of one phase 2 trial that is never published. I think it will probably work the same as IVIG, but we should wait for the results. And there's a question for Shahram. Recently, SPTLC1 mutation is found in ALS, like in hereditary sensory autonomic neuropathy. So is it possible that L-serine is useful in ALS with this mutation?
So one of the mimic of ALS is really one of the mimic is deficiency in riboflavin with cranial pair impairment, and it really should be detected. So if the level of, I don't know if it has been tried or not about this publication, but if the level of riboflavin, which is easy to measure, is decreased, yes. Okay,
great. And the last question I have for Shahram is about the SORD mutation. I have 2 patients with the SORD mutation.
Great.
I want to see if you are planning to start a clinical trial for all those reductase inhibitors in these patients. Maybe you can also include our patients in your trial.
Yeah, yes, this is
what CMT, and the same for CMT1A.
Yeah. Yes, yes.
We participate in the trial or not?
No, this is my great highest wishes that I can. I have many emails from patients from Iran or physicians from Iran hoping to include the patients in. The problem is that it is not possible to in the context of clinical trial, it's not possible to include countries who are not the clinical center are not open, you know. For example, in France, only French people who have social
security number.
Yes, can participate. Even the people from other countries, you cannot, from Germany or Europe, other countries, you cannot include them in a trial. But we have to try to work with the authorities to have to include Iran as a country with the clinical trials now that relations are improved in terms of political facilities, as I can say. Perhaps Andoni has some idea to, because even Turkey is not cannot participate in these trials. So I don't know what we can do to the more interesting people are in Iran.
Yes.
In terms of center, and in terms of patients.
Yeah. So we should wait for politics to improve. Okay. Thank you very much for wonderful lectures and also the questions and answers. I think we should move on to the next session. Farzad, will you continue?
Yes. I am going to start next session without delay. In next session, we will have 3 lectures from Dr. Lajrou and Dr. Otisburg, and the last would be with me. The next lecture is by Dr. Emmanuel Lajrou. Dr. Emmanuel Lajrou is a pediatric neurologist and also clinical trial investigator at iMotion and also medical manager at Geneton. I appreciate Emmanuel to accept our invitation, and I invite her to start her presentation.
Thanks a lot. I'm not sure you're seeing, do you see my screen correctly?
Yes, that's correct.
Yeah, okay, thanks, because I had a doubt. Happy to meet you for this meeting. Thanks a lot to the organizers for allowing me to talk about the therapeutic updates in DMD. So DMD, as you already know, is a lack of dystrophin. So dystrophin, that's this huge protein that is has both mechanical roles but also non-mechanical roles. The mechanical roles are mainly to maintain the sarcolemma, because as you can see on this slide, dystrophin is making the link between the extracellular matrix and the cytoskeleton. So obviously that's the major role for dystrophin in the muscle. But dystrophin also, we sometimes tend to forget, also is responsible for non-mechanical roles. One of the major role is the protein localization, because dystrophin is responsible especially for localizing nitric oxide synthase and aquaporin 4 in their adequate localization. If there's a problem of localization for nitric oxide synthase, especially, it will have consequences when people are having exercises, muscular exercises, because then the nitric oxide synthase will not be able to work correctly. The reactive oxide species will accumulate in the muscle, and then people will suffer from muscular fatigue. So that's one of the responsibilities for dystrophin. And also the last thing that is important is that dystrophin is also responsible for protein scaffolding. When dystrophin is not localized and working properly, other muscular proteins tend to scaffold irregularly, and then aggravating the muscular dysfunction. So we are talking about dystrophin deficiency. This deficiency can arise either from point mutation, duplication, deletions, whatever the mutation in the DMD gene. As we have already seen, this will disrupt the dystrophin associated complex, and then the sarcolemma will not be maintained correctly. It will create an increased permeability, and then the calcium, which should be outside of the muscular cell, will come into the muscular cell with the higher intracellular calcium concentration. Then proteases that are calcium dependent will activate, and cytokine chemokines will also be accumulating into the muscle. And so we arrive to these pathophysiological difficulties that you already know that are leading the necrosis and regeneration that is the hallmark of DMD. So we have inflammation. We will see that a couple therapeutics molecules are working against inflammation. We have the degeneration, the fibrosis. That's also one of the big topics for all the medication working on this fibrosis. We have the stem cells that will try to activate, but sometimes not efficiently. We have obviously the necrosis, the regeneration that is impaired. Then all the autophagus system must work to try and eliminate all the necrosis, but it's not working efficiently. And there's also some problems with the vasculature. So the therapies, as I already said, can target any of these anomalies. And we will try and see all of these available and incoming therapies. But the first thing is really to remember that therapeutic innovation must be associated to the standards of care, because if you are going for innovative therapies, but you're not providing your patient the best standards of care, obviously that's not logical. So the standards of care at the time, I'm just taking a couple of seconds to tell you again, it's obviously the physiotherapy. It's obviously taking steroids, whatever the steroids. It can be prednisone or prednisolone, 0.75 milligram per kilo. It can be deflazacort. It's not available everywhere, especially in France. It's not that easy to get deflazacort. Deflazacort, the regimen is 0.9 milligram per kilo every day. You have also to protect the heart. That's the protection with perindopril from around 8-10 years old. And then sometimes you will have to associate another cardiac medication. You also have to go and be really careful for the respiratory nerve. And when it's going to be needed, go for non-invasive and sometimes later on the invasive ventilation. And you also have to take care of the bone protection and all the orthopedic management, and also take care of the nutritional status of your patient, because some of the kids are tending to be overweight, obviously, because of the lack of movement and the steroids, but later, and especially for the adults, sometimes it's less, they are not weighing enough kilos. So the potential medications that could be arriving on the market, obviously we have two possibilities. Either we go for dystrophin restoration, or we go for something that is downstream. We're not working on dystrophin, but we are working on inflammation or fibrosis. To talk about the dystrophin restoration, the first possibility would be the cell therapy to give new myoblasts or pluripotent stem cells. At the time, it's not used. People are working on it, but we don't have that kind of medication. What is coming into the trials, we will talk about it at the end of the presentation, is the gene therapy. As you might know, at the time, 4 companies are working on gene therapies: Pfizer, Sarepta, Solid, and Geneton, either with micro, mini dystrophin, and we will talk about that. You can go also for gene correction. One of the possibilities is to edit the gene with CRISPR-Cas9. At the time also, as for the cell therapy, people are working on it, but we don't have gene editing possibilities that are coming quickly on the market, and no trial at the time. What we already have or is arriving is gene correction by other possibilities that are read through, as Professor Perreon has already described for Pompe disease. So we'll talk again about ataluren that is used in DMD. And there is also exon skipping with eteplirsen and all the same therapies. If we don't go for dystrophin restoration, we can go for other possibilities. We can try to work on the muscular mass. We had some hopes 2 or 3 years ago that some molecules could arrive on the market for that, but they have been abandoned because either the side effects were too important or the efficacy was not there. So nothing about working on the muscular mass at the time. One of the big topics we have is working, as I already said, on inflammation and fibrosis. We have the Tamoxifen. We are going to talk about that. We had, but it's been abandoned because of a lack of efficacy, a molecule that was edasadonexant. We have the new steroids, vamorolone, and we have molecules that are arriving in trials against fibrosis, Givinostat, Pamrevlumab, sorry. And we also have a new company, Akashi, that is working on, in fact, 3 molecules, as you're going to see, HT100 and DT200 and another one for calcium. So Akashi is also working on the metabolic pathway, working on the steroid receptors. So that's the DT200, but this one is only at the really beginning of the pipeline. And the last 2 possibilities are to work on alternate complexes, because if you don't work directly on dystrophin, you can decide to work on the other proteins that are in the protein complex. And so you can also do gene therapy, but for another protein that is GALGT2. So Sarepta is working on, the company Sarepta is working on this one. And last thing, you can try to work on the calcium, because if you remember, we said that when the sarcolemma is disrupted, the calcium will arrive into the muscular cell. So Akashi, once again, is working on this pipeline with the 8300 that would be, we hope, coming in the future. So I am sorry, I forgot also, because we tend to forget sometimes the heart. You can also specifically try and work on the cardiac part of the disease. So there's a company that is working on cardiosphere-derived cells. They are engineering stem cells that are specifically engineered to do cardiocytes, and then they put it on some small spheres, to the cardiospheres, to try and alleviate the cardiac symptoms. So what we'll discuss, I have said, is the gene correction, exon skipping and read-through, the anti-inflammatory and anti-fibrosis molecules, and then the gene therapy. So the exon skipping, I think you have already heard and seen probably this kind of slides. Exon skipping is based on the fact that some exons can be skipped. If you remember, in the DMD gene that has 79 exons, some of the exons end with a complete codon, as it's written down. Some of the exons will not end with a complete exon. The exon is completed by the following exon. And so, for example, if you take the 4748, a mutation that will delete both exons, does not change the reading frame. But if you take the exon 50, one of the hotspots in the disease, deleting the exon 50 changes the reading frame, and then you end with a Duchenne, a severe phenotype Duchenne muscular dystrophy. So one of the things that is possible is to skip exon 51, and then you can go from the 49 to the 52. And then you get a protein that obviously is smaller. So obviously you're not making all the phenotype go away, but you can alleviate the symptoms. The problem with exon skipping, yes, it's not working anymore. Sorry. Whoa. I'm sorry. Oh, yeah, it's okay. Do you see? Yeah. The problem with exon skipping, sorry, I was saying, is that you have to engineer the exon skipping for every every kind of skipping you want to perform. And so it depends on the exon that is skippable. If you take the 51, obviously that's the one that is the most frequent. So it's around 17-18% of the deletion that are in the LDMD database. Some of the time it's really less frequent. And in the end, by generating 12 antisense oligonucleotides, you can cover almost 75% of the boys. At the time for exon skipping, we already have 4 medications that are on the market. Sarepta has been able to take on the market eteplirsen, exon 51 for the exon 51, obviously, the golodirsen for exon 53, Vyondys, casimersen for exon 45, Amondys. And more recently, there's another company, NS Pharma, that has arrived on the market with Vitolarsen, exon 53, the Viltepso. So exon skipping obviously is one of the main translational possibility for DMD. Also can be used for other disease, obviously. The other possibility is the read-through, as Professor Perreon has already shown for Pompe disease. The read-through is the fact that usually ribosome will read the RNA and transform it into a functioning protein. If you have a stop codon, then the translation will be incomplete, and that's what happened for a couple of the boys in DMD. But if you have a nonsense, a specific nonsense stop codon, then ataluren, that has been created by PTC Therapeutics, can read through the stop codon, and then you can get a functioning protein. Once again, we are not talking about a full-length protein. We're talking about a protein that is smaller and will only partly alleviate the symptoms, but still it has shown efficacy on the muscular part for the boys. Efficacy or non-efficacy for ataluren has been discussed a lot. In a paper published at the end of last year, all the meta-analyses that have been done for this medication were once again studied, and it was concluded that there is indeed a significant difference for the 6-minute walking test with ataluren, and especially the treatment efficacy was most evident for the patient. We were at what is called the ambulatory transition phase at not the beginning, but the just beginning to get worse for ambulation. So the kids were especially helped with the treatment if the 6-minute walking distance was between 300 and 400 meters at the beginning of the treatment. So if we leave the gene correction, we've seen the exon skipping, we've seen the read-through therapies. Now we are going for therapies that are working on inflammation and fibrosis. You can work on inflammation with tamoxifen. Tamoxifen, that's the same tamoxifen you know for cancers. Tamoxifen has an anti-inflammatory efficacy that is through the estrogen receptor that is blocked by tamoxifen. Why did people go for tamoxifen in DMD? Is because it's been proven efficient in the mouse model. And so the TAM DMD trial has been set up 2 years ago, roughly. The kids are given 20 milligram tamoxifen or placebo once daily during 48 weeks. And we're still waiting for the results at the time. One of the interests that have been going for tamoxifen is the price of the medication. because treating with tamoxifen costs roughly €300 a year. Obviously, it's nothing in comparison of all the other innovating therapies. So, and also it's not dependent on the mutation. So we are still interested in seeing what tamoxifen can do. Oh, sorry, I still have a problem with my... if we are still talking about inflammation, what is next in this topic? We have two things that are in trials at the time. We have the Geminostat, a company named Italfarmaco. Geminostat is has a HDAC inhibitory activity, so it's working against inflammation for this property, and it's evaluated at the time. And another trial that is beginning, it has begun for non-ambulatory boys, and it will also begin for ambulatory GMD boys, is the one from Fibrogene, Parvum. This medication is an antibody that is targeting the pro-fibrotic connective tissue growth factor, and for that way is working also against fibrosis. And as I already said, the one that was we were hopeful with the medication from catalysis, but etazanexon has been finally abandoned last year because of lack of efficacy. To finish this talk, I will talk a bit about gene therapy. So we go back at the beginning to gene correction, but I wanted to talk about it at the end because it's only really the beginning. So gene therapy, when we are talking about gene therapy for GMD, we're talking about in vivo gene therapy, because, for example, for CAR T cells, you take the cells out of the patient, you do all the gene therapy things you have to do, and then you put them back. For GMD, it's in vivo gene therapy. You use usually an AAV, adeno-associated virus, that is like a kind of a suitcase. You're putting your DMD part of the gene inside, and then the virus will do its job and infect the patient, and then deliver part of the DMD gene. The problem with DMD gene therapy, for example, in comparison to spinal muscular atrophy, is that the DMD gene is a huge one. So you can't put all the DMD gene in the AAV. You have to decide which part you're taking. So you have globally two possibilities. Either you make a mini dystrophin, either you make a microdystrophin. If we go for the microdystrophin first, the microdystrophins, they are the smaller one. They are 3.5 up to 4 kilobase, and so they can fit into a single AAV. If you construct mini dystrophin, they are heavier, 6 up to 8 kilobases, and so they can't fit into a single AAV. But one of the skill for the mini dystrophin is that they usually contains the C-terminal domain. I won't explain everything, but just believe me when I say that this C-terminal domain has interesting properties. So I said at the beginning, the GMD gene therapy at the time, we have 4 companies, Geneton, Pfizer, Sarepta, and Solid. They use either AAV8, AAV9, or AAV RH74. So one of the main problems with gene therapy is that it excludes kids with pre-existing antibodies. And for example, for AAV9 at the time, it's something like 40% of the kids. So a huge part of the kids won't be able to benefit from this therapy. And also, obviously, the good thing is that it's a one shot, but the bad thing is also that it's a one shot. We don't know at the time how long it's gonna, if it's gonna be working, how long it might be working. And if it's not working, definitely, at the time, we're still not able to re-inject the patients. Once again, even if it's gene therapy, we're not talking about something that will make all the symptoms disappear, because we are not putting all the gene into the gene therapy, as I already explained. And you also have to remember that gene therapy has potential severe side effects. It has been seen in Sarepta, but also for Spinomuscular Atrophy with Duchenne SMA. You have thrombotic microangiopathy. You have atypical hemolytic uremic syndrome, myositis, thrombocytopenia. So people have to be able to take care of all these potential side effects. And I'm not talking about the price, but you understand that the price is a huge problem. So if we finish this talk, I'm just using a slide that Professor Perrion has had the kindness to show me. I wanted to remind you that we are talking first about the standards of care, and then you can go for a gene therapy, you can go for a modifying treatment, you can go for a symptomatic treatment, but really you have to remember to go for the standards of care first. So as a conclusion, we have many innovative therapies that are either already on the market or some are coming on the way. You have to remember that sometimes they are mutation dependent, so they are not available for all the kids. Sometimes the kids will have antibodies, so they will not be eligible. We will need in the future cost effectiveness studies, because the health system, whatever the country, won't be able to support all these new gene therapies and expensive treatments, and always associate them to the standards of care. I thank you for your attention. I'm really sorry I'm ill today, as you might have understood, so it was a bit difficult for me. Thank you.
Emmanuel, many thanks for your attractive presentation. It was absolutely useful for me and also for our participants. I'm not sure if you could stay with us for the question and answer section, or? Yeah, thank you.
Yeah, I'm staying.
Okay. I am going to introduce the next speaker, that's Antonio Otisburg. I believe that he doesn't need to be introduced because many people that are here know him. Antonio has traveled a lot to Iran, and many neurologists, pediatric neurologists know him, and also many patients are in contact with him. Antonio is pediatric neurologist and also rehab specialist, currently faculty at the Institute of Myology at Paris, and also head of Académie Mayo, that I believe that it would be held in next month as a virtual of Summer School of Myology. Anthony?
Okay, Khalim Mamnoon, Farzad, for your nice introduction, and salam to everyone. Yes, it's my pleasure to be with you today to share some thoughts about the recent therapeutic advances in spinal muscular atrophy. So I guess you can see my screen. It's okay. So
yes,
these are my disclosures. Just for those of you who are not familiar with spinal muscular atrophy, it's up there, okay, in this group of motor neuron diseases. And there are various types, and we're going to get back to that later on. Today, we're going to mainly concentrate on 5q SMA. That is the classical form of SMA. But as you should remember, and as mentioned by Professor Attarion, there are also other forms of spinal muscular atrophies which are amenable to treatment, like the Faziolonde and the Brown-Violletto-Van Loo syndrome. But today we're talking about the classical one, the classical SMA, and as you all know, it's an autosomal recessive disorder. It's pretty common, by the way. The incidences might be extremely high, especially in the Middle East, or where consanguinity is endemic. Remember as well that among the three types we know, the main three types we know, type 1, type 2, and type 3, the distribution is different. Okay, so the mainstream population of SMA is type 1, 60%, followed by type 2 by 25%, and type 3 by 15%. So just as an example, in our country, in France, it's an overall population of 65 million people. We have yearly around 100 new cases of SMA, and we have currently living in the country about 1,200 people. So it's common, and those people are really demanding for treatment, and have been doing so for many, many years. We know how SMA works, in brackets, and remember that it's due to a deletion in the SMN1 gene. So this gene is here, as you can see here. This gene is made of 8 exons leading to a messenger RNA, a full one, I would say, incorporating the exon 7 here, and leading to the production of a full SMN protein. Just nearby, there's another gene, almost identical gene called SMN2, and the main difference is here. It's just a single nucleotide change, but just because of that, exon 7 won't be incorporated in the messenger RNA, and therefore the full-length SMN protein will not produce, or would be produced in a very little quantity, not enough to make motor neurons survive. So that's how it works, and therefore when you don't have any SMN1 gene because it's deleted, then you only rely on the SMN2 gene to produce this little amount of full-length protein. Hopefully, we do have several copies of SMN2 in our genome, and the more copies you have, the better, because you'll be able to produce more and more SMN protein. Just to remind you that, of course, the clinical diagnosis, the diagnosis of SMA is mainly clinical. You know, many of you, all of you know how to recognize such patients. They're floppy, they have no reflexes, they're all the same, more or less. But you have to confirm that at the molecular level, and therefore you have to screen the SMN1 gene first, and you will look at the presence of a deletion. It's usually a homozygous deletion. Sometimes it's a heterozygous deletion plus a point mutation in the SMN1 gene, but it doesn't matter. You can still further confirm the diagnosis that way. And more importantly, and it's becoming key nowadays, you need to measure the number of copies of SMN2, because it will have some implications at the therapeutic level as well as the prognostic level. As I said, the SMN2 copy number is now a biomarker by itself, in the sense that it helps you to predict the prognosis, and it helps you to prescribe the innovative drugs we're going to talk about. So obviously, when you do have only one copy or two copies of SMN2, then you're quite likely to have a very severe form of SMA. Whereas if you have 4 or more, then it's going to be better for you. It is nowadays difficult to categorize each SMA patient. We do have this sort of robust classification, I would say, from type 0, type 1, type 2, type 3, and 4, and so forth. We can rely on the SMN2 copy number. That's true. We can rely on the age of onset. We can rely on the maximum motor function the child is going to achieve. But there are still cases where it's difficult. There are exceptions, and there are, I would say, outliers. And this is difficult when at the time of prescribing the therapies. And therefore, the phenotypes are quite variable in SMA. This is just an example of type 0, type 1A, B, and C, type 2, type 3, type 4. And what's even more fascinating is that nowadays, because of the therapies being on the market, the phenotypes are changing. We do have type 1 patients, for instance, that that survive very long. They might be, and they will probably be disabled, but are still surviving. Now, coming to the main issue, or the main topic, which is about therapies, just a few words about what I call semantics. You have to be careful when you talk about therapies, especially if you address this issue with parents, because a cure is different from a therapy. A clinical trial is not a therapy exactly. Prophylaxis is also part of the therapeutic interventions. When we're talking about approval of a drug, that doesn't necessarily mean that the drug will be reimbursed or available everywhere, as we will see. And finally, it's important to promote hope for your patients, but you have to be careful and not to oversell the drugs that you're going to prescribe for them. So yes, we are just facing an ongoing therapeutic revolution in SMA. We have 3 drugs approved both by FDA in the USA and by EMA in Europe. So we're going to talk about the nusinersen, yes, that's the oligo-antisense nucleotides, the gene therapy, and the small molecule called risdiplam. In terms of efficacy, and we'll come back to it, at least the 2 first show a dramatic impact on survival of type 1, that's for sure. And at this point, but this might be variable from one country to another, Spinraza, that is nusinersen, is probably more appropriate for type 1 and type 2 patients. Zolgensma, which is onasemnogene, Parvum is more appropriate for type 1 and perhaps type 2. And Evrysdi, the risdiplam, targets more promptly, more type 2 patients and type 3 patients. On this diagram, I just wanted to show you that there are 2 ways of addressing the therapeutic issue we have with the SMA. Either you target the production of SMN, okay, you can replace the gene to do that, you can put oligos to do that, or you can put a small molecule like risdiplam, and it has been shown to be efficient, first in animal models and nowadays in humans. And the other way to do some good to SMA patients is to target non-SMN protein mechanisms. In other words, you may be tempted to protect the motor neuron, for instance. You may be interested by a muscle activator, as shown here, and so on and so forth. The message is that in SMA, so far we only use this first avenue, but most probably, and in the coming years, we will also use this other avenue, which is a good sign and for hope. In other words, that more companies will be entering the market and will propose new drugs. So the first drug to be approved by FDA just as a Christmas gift in December in 2016 was nusinersen, also marketed as Spinraza. You probably remember how it works. You remember what I showed earlier on about this scheme, the SMN1 gene and the SMN2 gene, and therefore what we'd like to have in the SMN2 messenger RNA, which is naturally lacking the exon 7, is to reincorporate this exon 7 within this mRNA. And to do that, we're only using this ASO, this antisense oligonucleotide, which is going to be able to do that, okay? And that works perfectly. That works in mice, that works in humans. The only problem is that you need to inject this compound in the CSF, okay? So you need a lumbar puncture, and you need to do that regularly, okay? Every 2 weeks in the beginning, and then every 4 months on a regular basis. This drug has been subjected to many clinical trials, as you remember, ENDEAR, CHERISH, NURTURE, EMBRACE, targeting different populations of SMA patients, and all did similar results, I mean, showing efficacy, showing good safety profile. And more importantly, in my view, is this NURTURE study showing that if you intervene extremely rapidly before symptoms occur, then the patient will develop normally. And this is just like a miracle drug in that sense, and we'll come back to it. So these are the scientific data to show efficacy among the various studies performed by Biogen in the past years. And again, if you look at the two best results here in the red line and the blue line here, it's when you give this treatment in pre-symptomatic children, whatever the number of SMN2 they have. Here, there's 3 copies, and here when they have 2 copies. So we have evidence that it works, and it started to be prescribed and given to many patients. So that's the situation nowadays. So it's been approved, as I said. It's indicated for all types of SMA. Well, that's the way it's labeled. The pricing policy is still debated, but because it's extremely expensive, as you can see here, some skyrocketing prices. And it's been widely used. To date, 11,000 people with SMA have been exposed to Spinraza with a very good safety profile, and that's good news. And in terms of efficacy, yes, it showed significant improvement, at least in type 1, a little less in type 2 and type 3 patients, but it's generally prescribed. So as remember, it's intrathecally injected. First year, you need 6 injections, and then 1 injections every 4 months. And I just had an update of the French experience. Remember, we have roughly 100 new cases of SMA per year, and among them 30 to 40 are type 1 patients. Regarding nusinersen prescription, we had an expanded access program to start with, and nowadays it's widely available and prescribed. And so far we are treating 200 to 250 patients with this drug. So the safety is good, as I mentioned. There are good and poor responders. We all know that, especially in type 1 patients, it's difficult. They may improve at the motor level, but remain bulbar and having bad scoliosis to deal with. And we mentioned the last point here that ethically we have a number of issues raised, not only with nusinersen, but with all these type 1 patients that we're treating. Should we treat them? How should we select them for specific treatment? It's still very debated. So if you're interested to know more about the French experience, you can rely or refer to this excellent paper by the French group of child neurologists prescribing nusinersen, and they treated 123 children with type 1 SMA or type 2 SMA, and it's a very interesting paper. Regarding adults, and it's a growing concern nowadays because the demand is growing. So it could be either old type 1 or type 2 patients we are just aging, or it could be new type 3 patients being recently diagnosed. The point is that we have no real scientific evidence. There have never been any randomized clinical trials for SMA type 3 patients, for instance. But still, we are keen to prescribe the drug and to see whether it's worthwhile. And that's why you see in the literature many open studies reporting motor improvement. Yes, that's for sure. But it's never dramatic in the sense that it could be just more strength in fingers or in hand flexion. But that might be very useful to the patient. As you probably guess, we do have problems when it comes to inject these patients when they have very bad scoliosis or kyphoscoliosis. But still we manage that with the radio intervention or with the help of good radiologists. For this particular population, the adult population with SMA, we're still lacking personalized or really relevant outcome measures, especially in the upper limb. How do we measure they're really improving with this drug? And we can predict that nusinersen in this context will probably compete very much with risdiplam, which is given orally, as we will see. The second drug we're talking about is the Sims gene, abupavir, which is called Zolgensma. Okay, remember it's a gene replacement therapy. This is what we're injecting. Remember, we're using a transgene. Okay, here it's a human transgene, but it's a small one, as opposed to the transgene for DMD, which is huge. Here we deal with a small gene, and therefore it's easy to pack within a virus, such as the AAV9, as shown here. This particular virus crosses the blood-brain barrier, and it targets neurons. That's excellent news for us. And it's not integrating, it's non-pathogenic. It results in a rapid and sustained SMN expression, and, which is very interesting, it remains stable within the nucleus for years, supposedly for years. So we do have to make one unique intravenous infusion to do that. The vector will incorporate into target cells via endosomes. The therapeutic DNA will enter the nucleus, forms an episome ready for transcription, and then this mRNA is transcribed, leaves the nucleus, and is translated into the SMN protein in the cytoplasm. And therefore, you have a sustained SMN synthesis, which prevents the loss of further motor neurons. Take this, perhaps not for granted, but the transgene is supposed to live or to persist within the cell for around 10 years, okay? What's going to happen after 10 years, we don't know, okay? And this is another matter of concern. Just to remind you that this was the very pivotal trial for Zolgensma, okay? It was a phase 1, and this gentleman, Jerry Mendel, is the real pioneer in SMA gene therapy. He took only 9 and then 6 other children to start with, all with SMA type 1. They're very pretty young. He just dosed them with a systemic delivery of this AAV9 containing the SMN1 gene. And the endpoints were met, and the efficacy was shown very rapidly. How did they show efficacy? Just by using a CHOP INTEND score here, which is the motor scale we're using for infants, and which showed if you use the cohort with the good or the right dose of the gene product, and then that the CHOP INTEND is really improving over time. Whereas the natural history shows generally that those children will not survive before or more than 2 years in general. Okay, so efficacy is there, and that's why it's been a major breakthrough in SMA. And if you look at this girl had, in theory, type 1 SMA. She only had 2 copies of SMN2, but she got dosed on the right time, and she developed almost normally. So remember, for those of you who are going to be prescribing gene therapy, I know it's not yet available in Iran. I think people have to go to Dubai till now, but still, I'm pretty sure it's going to happen and it'll be available in your country. So you obviously need some prerequisites, like obviously you need some molecular genetics to be sure it's a genuine SMA case. You need to know the SMN2 copy number. You need to screen for the presence of or the absence of AAV9 antibodies, and then you will inject the child. But you have to do that in a hospital setting. You need to monitor the child for at least 2 days, and most probably more days than that, and so on and so forth. You need to check for fever, vomiting, transaminases, for liver failure, whatever, and all sorts of problems. And remember that because we're using a gene therapy product, we probably need to prescribe steroids, just at the moment, at the time of injection, but also during 1 month. So to date, what do we know? 300 children, exclusively infants, have been exposed to Zolgensma to date. The safety profile is good in general, but there are a few serious adverse effects reported, and I'll talk about it in the French experience. Yes, and the main issue is about accessibility, I would say, because despite compassionate use, there's an early access program by Novartis in some countries, it's still difficult to get access to it. So that's the French experience with Zolgensma. The latest data, which are not yet published, showed that 28 type 1 SMA patients have been treated to date with this drug. The safety profile was good in general. We even had a very good outcome with a girl treated pre-symptomatically, which developed normally, and she's able to run nowadays. And whereas a brother has not been treated by Zolgensma and is still very disabled. So our concern today is about safety. In our experience, we had 2 deaths. One was due to lack of efficacy, clearly, but the other one was really related to a serious side effect called the thrombotic microangiopathy, TMA. So beware of that, because it could be lethal, and it's a major concern. Of course, we can treat it, but sometimes a patient doesn't survive. The third drug available on the market is Evrysdi or Risdiplam. It's a small molecule. It's not an oligoantisense nucleotide, but it acts on the same splicing machinery, as we will see. So Risdiplam has been investigated in several clinical trials. I'm not going to describe all this, but you've probably heard of all these fishes here: 5-fish, sunfish, jewelfish, rainbow fish, all of them targeting specific populations of SMA, type 1, type 1 and 2. And the rainbow fish study also looks very promising, because they also target pre-symptomatic SMA. This is just one example of efficacy. If you use the same Charpington score over time in this type 1 children, yes, they improve. Okay, the improvement is not as dramatic probably as nusinersen, but still. So this is what we know about this drug. It's a small molecule, as I said. It's given orally, and that's good news, because it's far more simple than dosing via a lumbar puncture like nusinersen. The effect seems immediate, in the sense that within a couple of days you will see the child improving at the motor function level. It's well tolerated, and in France, as far as I know, we have around 100 patients treated, and mostly adults where it's not amenable, or because it's difficult to dose them with nusinersen. And Dr. Lagrue and others are just working on a project of a comparative study between nusinersen and Risdiplam in the coming months or years, because we don't have this comparison with the drugs. Then that's another issue. So I'd like to end up my talk with 2 related issues, which is the newborn screening, because what I told you before is that if you intervene very early, at a time when the child has no symptom at all, you're likely to be very, very efficient. Okay, you may save your patient's life, and he will develop, or he might develop normally. And how do we diagnose patients early? Well, if you have a very good network of child neurologists trying to detect every motor symptoms in every child, yes, but that's not very, very efficient. What's probably more efficient is to screen children at birth via a molecular test. Okay, that's what we call the newborn screening. There have been a number of papers about that, and because nowadays we have effective drugs, this programs meet the Wilson and Jungner criteria, which are necessary to embark on NBS in a given disease. So yes, it's important. It's done on a Guthrie con. few days after birth. You need to organize this very well. You need to refer immediately the patients which have been detected to the child neurologist for further evaluation and for control, because sometimes we have false positive or false negative. And then you need to start treatment. I mean, you need to obviously propose some medication. So NPS is not available everywhere. This is just one example. In the US, there are a growing number of US states implementing SMA newborn screening. In Europe, and this slide is a little outdated, it's coming. Germany is going to do a nationwide NBS program. France, we're going to have 2 pilot programs very soon. Similarly in Italy and other countries. So it's coming. In the Middle East, I don't know. I think it would be worthwhile, given the high incidence of SMA in the region. I know that Saudi Arabia is talking about it. Israel is just screening not the newborns, but the parents, just to know whether they are carriers. So that there are a number, and it's a number of papers and reports and studies in this field. As Dr. Lagri said about the standards of care, which are key when you deal with such patients, the same message applies to SMA. You need to treat them for orthopedics, for ventilation, for nutrition, emergencies, and so on and so forth. And you need a coordinator. You need a multidisciplinary team to achieve that. So this is still true. This is very useful, and this is not very cheap, very expensive, as opposed to all this very skyrocketing drugs. Now, my take-home messages for you guys are there. So this is an ongoing therapeutic revolution, certainly, but you have to tell the truth to your patients. In other words, don't tell them that you're going to make them as normal children. No, you can't say that. If you have a type 1 child, you may tell them, yes, we're going to improve him. He's going to survive for sure. He might not be able to walk, and it's very unlikely that he's going to walk. If it's type 2 patients, then you have to tell them, yes, we will probably improve him a little, perhaps dramatically in some cases. Perhaps a few % of them will be able to walk, but it's still to be demonstrated, and so on and so forth. So be honest and don't oversell these drugs. I mentioned the strategic importance of early diagnosis, newborn screening or premarital screening, especially in the region. And another point is about who makes the decision about such drugs. In France, at least, we discuss this collectively. We have a committee, a nationwide committee, which is extremely active and reactive, and we analyze every case on a case-by-case basis, okay? Weighing the pros and cons of each drug for each patient, and that's very useful, and we learn a lot with these meetings. As I said, ethical issues are a growing concern for SMA, to which extent we should be proactive, and never remember that even in France, where we have access to all these drugs, a significant proportion of parents decide not to treat, okay? Approximately 30%, perhaps 40% of type 1 patients or parents of type 1 patients don't want these drugs for all sorts of reasons, and we have to accept this decision. And to finish, I'd like to say that the problem of accessibility is still remaining in many countries. We have to fight. You have to fight. You have to lobby the pharmaceutical companies. You have to lobby the government to give access to these drugs to these children, because they deserve it. Okay, so with this, I think it's enough. So thank you for your attention, and thanks again for the organizers, and I'm ready to take questions.
Thank you very much, Anthony, for your nice presentation. We will come back to you for question and answers. Okay, the next speaker is me. I hope that you have my screen. My speech is about therapeutic updates in autoimmune polyneuropathies. Because we have not too much time, I will be very quick, and I know that you are tired after 2 hours and 45 minutes of webinar. I am going to talk about brief introduction of inflammatory neuropathies and also subcutaneous immunoglobulin in inflammatory neuropathies, rituximab, bortezomib, and also stem cell therapy, and some of recommendations for the treatment of inflammatory neuropathies. Inflammatory neuropathies or polyneuropathies include an spectrum of disorders that mostly and the highest prevalence is typical CIDP that we know the disorder, and also its variants such as DATS or distal acquired demyelinating symmetric neuropathy, MASAM disorder, pure sensory form of CIDP, chronic immune sensory polyradiculopathy, pure motor form, focal variant, and a group of recently introduced neuropathy CIDP with IgG4 antibodies and also multifocal motor neuropathy. And also this nice picture demonstrates various forms of immune neuropathies. As you see, the highest prevalence belongs to CIDP or typical CIDP that is about 50% of the population of inflammatory neuropathies. After that, we have distal predominant, sensory predominant, and also IgG4 paranodal or nodal antibodies that comprise around less than 10% of patients. As you know, the usual treatments include IVIG that's responsive in higher than 80% of patients, and also other treatments such as prednisolone, plasma exchange, and if not responded, we use cytotoxic medications such as azathioprine, mycophenolate mofetil, and also cyclosporine. A recently introduced medication is subcutaneous immunoglobulin or Hizentra. The main advantage of this medication is self-administration by the patient at home. As you know, the main barrier for IVIG is that most of patients should be referred to a center for administration of IVIG, especially at this epoch that we have encountered COVID-19. It may be difficult for the patients, even in outpatient centers, and with the introduction of SCIG for the patient, it's possible to inject immunoglobulin at home by themselves, and it's very absolutely easy, and it can improve patients' quality of life. This is a PASS study, or the polyneuropathy and treatment with Hizentra, that was published in 2018, and after this study, FDA gave the approval for this medication. In this study, 172 IVIG dependent CIDP patients were enrolled, and they were prescribed SCIG or Hizentra with the doses of 0.2 gram per kg per week and also 0.4, and another arm of placebo group for 24 weeks. And as you see here in this survival analysis, the outcome was the proportion of patients who had a CIDP relapse or were withdrawn from the study for any reason. Here, the gray line indicates the placebo group, the red line indicates the low-dose SCIG group, and the blue line indicates the high-dose SCIG. As you see here, the patients with low-dose or high-dose SCIG did better than placebo group, and after this study, FDA approved the SCIG for patients as a maintenance therapy for CIDP. In this study, there were some adverse events such as local infusion. That was the most important reaction, but it was usually mild or moderate, not significant, and it was seen in 30% of low-dose SCIG and 35% of high-dose SCIG, and also 18% of placebo group. And as I said, after that, FDA approved this medication. SCIG is usually an option for the patients who have difficult venous access and also had substantial side effects associated with IVIG, especially its introduction, and also living far away from infusion centers. And currently at this epoch, the patient not willing to be hospitalized or injected at outpatient clinics due to fear of COVID-19. There are two schedules for injection of SCIG. We can start with low dose treatment, that's 0.2 gram per kg per week. If no satisfactory response was attained, we can increase the dose to high dose regime, that's around 0.4 gram per kg per week. The problem is that SCIG is not ordinary at the moment in Iran, but I hope that in coming years it will come in Iran too. It's the schema for the injection of the SCIG, as you see. It could be injected in abdomen, also in anterior of thigh, and also in back of upper arm. Another option in rituximab is in CIDP is rituximab. Unfortunately, there are not randomized trials for rituximab in CIDP, but in some patients that are resistant to usual treatment, we use rituximab. As you know, rituximab is a most human chimeric monoclonal antibody that is usually used for B-cell lymphoma, but we can use it for many immunological disorders such as Myasthenia Gravis or CIDP. At the moment, a randomized clinical trial is ongoing in Japan, but the results are not delivered yet. In this study, they are comparing the group of rituximab with placebo group, and it's significant that all patients with CIDP, even with paranodal antibodies, are enrolled in this study. There are some case series or some case report for the use of rituximab in CID patient. For example, in this recent study that's performed in 2020, they use rituximab for the treatment of the patient with resistant CIDP, and the scales such as MRC sum score, INCAT, and also ONLS was used to evaluate the patient, and satisfactory response was seen in some patients, not all patients with rituximab. Also, rituximab is used in patients with neuropathy with anti-myelin associated glycoprotein antibodies or anti-MAG neuropathies. As you know, anti-MAG neuropathy is a special form of CIDP that usually presents with mainly sensory symptoms, mainly sensory ataxia, and also in electrodiagnostic study, you may see the increment of distal motor latencies that's unique to this form of CIDP. Despite the obvious autoimmune mechanism for this disorder, they are usually resistant to plasma exchange, and they may respond to prednisone or IVIG or cyclophosphamide, and usually the benefit is minimal or transient. There are some studies that have used rituximab in neuropathies with anti-MAG neuropathy. Most of them are old studies. This study is done by Professor Attarian in Marseille. And as you see, in 6 patients with anti-MAG neuropathy, there was significant benefit of rituximab in improving scales such as ONLS or electrodiagnostic scales such as CMAP amplitude. And it shows that rituximab may be a good option for patients with anti-MAG neuropathy that are resistant to rituximab. A recent introduced form of CIDP is nodopathies and paranodopathies. As you know, there are some proteins in RAMVN node, in myelin part or also axon part. They stitch myelin and also axon together, they paste together these proteins. And if we had antibodies against these proteins, that could separate the myelin from axon, and it causes a demyelination. These are usually resistant to usual treatments, and also rituximab may be one option for these patients. And this is a study that indicates rituximab may be an option for treatment-resistant CID patient with antibodies against paranodal proteins. As you see here, in 3 patients, OLS improved, and also the concentration of paranodal antibodies decreased after rituximab treatment. I briefly explain about our experience. In our center, we retrospectively analyzed response to rituximab in 14 Iranian patients with refractory CIDP, including 3 children and 11 adults, in whom, unfortunately, the status of antiparanodal antibody is not known, and we use MRC in CAT and also electrophysiological studies for patients' follow-up. And we define refractory CIDP as patient with unchanged or aggravated functional status following combination of prednisolone, 1 milligram per kg per day, plus monthly IVIG or plasma exchange, and also second-line immunosuppression, including azathioprine or cyclosporine or methotrexate for at least 6 months, or any severe side effects with medications or clinical relapse on the reduction of steroid dosage. The mean age was around 35, and the disease duration before rituximab treatment was around 27. As you see here, in most of the patients, we had decrement of prednisolone dose and also improvement of upper MRC or lower MRC, and also the improvement of other CIDP scales such as INCAT or ONLS, and also nerve conduction study. And here you see that the prednisone dosage decreased from 30 to around 7 milligrams per day, and also MRC sum score increased, for example, from 25 to 30, and INCAT also improved significantly with a good effect size. That's another case report that used ocrelizumab instead of rituximab, and the reason for using ocrelizumab was that the patient was unresponsive to rituximab, and when they measured the concentration of antibody to rituximab, they understood that the antibody titer was very high. Therefore, they tried to use another form of anti-CD20 medication, ocrelizumab, and after that, the patient responded very nicely. And it indicates that if the patient was resistant to rituximab, there is an option to change it to ocrelizumab in this case report. Another medication that has been used is bortezomib. Bortezomib or Velcade is a proteasome inhibitor tackling highly metabolic active cell types, and is usually used as an anti-cancer medication in patients with multiple myeloma or lymphoma. There is one study that used bortezomib in 10 refractory CIDP patients, and the patient reported benefit with bortezomib or Velcade. And the another option is hematopoietic stem cell transplantation. Hematopoietic stem cell transplantation could be used to aim eradicating autoreactive immune cells and also rebuilding a new immune system. Currently, hematopoietic stem cell transplantation is used for refractory CIDP patients. It could be used autologous or allogenic, but according to European Society for Blood and Marrow Transplantation, peripheral blood stem cell is preferred to autologous hematopoietic stem cell transplantation. And from 2002 to 2018, about 70 cases with refractory CIDP are treated with stem cells, and in some of them, the response has been very favorable. And at the last, I will tell you about the summary of recommendations for different types of autoimmune polyneuropathies. For typical CIDP, usually they respond to IVIG, corticosteroid, and plasma exchange, and higher than 80% of the patients respond to ordinary treatments. In atypical CIDP patients, in asymmetrical or MATSAM and also focal CIDP patients, they usually respond also to IVIG, corticosteroid, and plasma exchange, but in form of distal predominant or that's variant of CIDP, they may deteriorate with plasma exchange and they usually respond to IVIG or corticosteroids. And if they didn't respond to such medication, we can try rituximab. In motor predominant patients, also IVIG is effective. Even the patient may deteriorate with plasma exchange. And in sensory predominant, also IVIG, corticosteroid, and plasma exchange are effective. And also in IgG4 antibody, as I said, we have various forms of autoantibodies. Usually they have partial response or poor response to IVIG, and other medications such as rituximab or ocrelizumab could be used as an adjunctive treatment. And this is the last slide about what I told about you. I typed very quickly because the shortage of time, and I am going to question and answer section. Okay. I am going to read the questions. Okay, the first question is from Emmanuel. Is gene therapy in Duchenne muscular dystrophy as effective in treating cardiac problems as in treating motor systems and also in cognitive problems or scoliosis?
For the cardiac difficulties, we hope so, but obviously we don't have the proof at the time because it takes a long time to see a positive protective effect since it's happening later in the natural history of the disease. So we do hope it's going to work on it, but we don't have proof at the time. It's been the case in animal models, but we have to confirm it in DMD boys. For the scoliosis, I would say if the motor effect is there, then we should see an effect on the scoliosis because it's linked to the effect of the skeletal muscles. So obviously it should be better with the gene therapy if it works on the global motor symptoms. For the cognitive effects, no, we are not awaiting for positive effects on the cognitive disorders because of the way that's isoforms that are responsible for the cognitive disability in DMD. So we don't have effect on that part, and it's not going to be a solution with gene therapy.
Okay, thank you. Another question is my question from you. You talked about the anti-inflammatory medications in limb-girdle muscular dystrophies or like that. Do you have any experience with prednisolone or deflazacort in other dystrophies other than Duchenne muscular dystrophy, such as Spinal?
Yeah, it's been tested for steroids in other dystrophies, especially LMNA gene. In France, it's been tested by the group who is especially working on that muscular dystrophy, Giselle Von and colleagues, and they are inciting clinicians to put the kids on steroids. And I have a personal clinical experience of a real positive effect on steroids in LMNA muscular dystrophy.
Okay, thank you. The next question is from Andoni. As you said, some patients with the same genetic study for SMN1 or 2 have different phenotypes. So it seems there are other genes which are involved in phenotype presentation. Are there any study for these genes and use of them for the treatment?
Yes, it's a relevant question because, as mentioned, phenotypes might be quite variable. That's true. Even though the child has the same, well, the children have the same genotype, okay, in terms of SMN2 and SMN1 genes. Now, the SMN2 gene is a gross modified gene, okay, and that's very useful till now. There are many groups trying to identify other polymorphisms in other genes or just within this SMN2 gene or even in the SMN1 gene to predict among the children those who are going to have a more severe phenotype and those who are going more benign, okay? So this work is still going on, but it's not used in practical terms routinely. No, it's not yet available for clinicians.
Okay, thank you. Another question is from Andoni. Is the only advantage of risdiplam over nusinersen that's taken orally or any other benefits?
This is a good question, but I think Emmanuel could also answer this question because she's more used to this drug. But
at the time, we don't have the answer. That's the problem.
Yeah, it's still a dilemma at this point because we lack experience, we lack data, we lack, all this on the long run. We know, for instance, yes, it's given orally. This looks fantastic, but at the same time, you need to store this drug very carefully in a freezer or in a something. It has to be safe. And second, as opposed to nusinersen, where you know what you give, okay, because you inject the child. With risdiplam, well, you obviously prescribe, but the child may not take it 100%, for all sorts of reasons. So at this point, yes, it's an advantage to be given orally, but in the long run, I'm not sure it's going to be making a huge difference. I don't know what you think, Emmanuel.
The problem at the time is that we all would like to have this perfectly performed trial comparing kids that have, I won't say the same phenotype because, as you were saying, phenotypes they are always not the same. But if we could have the same global baseline for the patients and give them either one of the 3 therapies and see how it's going, then we would be really happy. Obviously, it won't be possible. So what we're trying to do at the time is, as Andoni showed you about the French experience with nusinersen, we're trying to collect the data in real life and have clinical information as precise as possible to be able in the long run to tell if one of the medication is working more than the other, and especially working more maybe in a subset of the patients, because once again, as Andoni was saying, maybe it's possible that one of the medication might be working better in one of the subset of patients or another. The problem is that from the beginning it's a bit biased because risdiplam has been given more to patients that were having problems to get the administration with nusinersen, obviously, because the prescription for Zolgensma SMA is limited to the smallest kids. And when the kids are growing older and administrating with the intrathecal administration is beginning to be difficult because of the scoliosis. Obviously, the decision for a couple of kids was to go for risdiplam, but then from the beginning it's biased. So that's really the problem in real life. We're trying to stratify things to be able to determine if one of the medication is working better, and if one of the population is, it could be more relevant for one of the other medication, and obviously always taking into account the price, which at the time is roughly the same, but...
And another point is, I think I would like to stress the importance of the registry, okay?
Yeah.
Because we are just producing so much data, over time, giving these drugs to these children, and we need to retrieve the information to draw conclusions in terms of prescription and also in terms of safety, because as I said, on the long run, all these new fancy drugs, we don't know what's going to happen, okay? So the idea of a national registry, you can do it in Iran. Perhaps it exists already. I don't know, but it's very, very useful.
Okay. Dr. Nafti, do you have any comment for National Registry of SMA?
We are trying to set up a registry for neuromuscular patients, and we already have a registry for SMA. Dr. Ashrafi is responsible for the registry, and he has already registered something like 600 or
excellent.
Like that. I'm not sure about the number, but it has exceeded 600 SMA patients. I have a question for Andoni. Has this been a study that what percentage of SMN protein is replaced after gene therapy? And do you think there is any place for combination therapy, like Spinomuscular plus Zolgensma or Risdiplam plus Zolgensma?
Yeah. Alors, in terms of the production of SMN protein, it's been shown in mice for sure, okay, for gene therapy. In humans, it's more difficult because it's difficult to measure, you know, the content of SMN protein either in blood or even in CSF. That's not easy, and it's not routinely done. But my guess is that yes, it showed perhaps 20% or perhaps more, I don't remember, of increase. The second question is about combination therapy. Yes, I didn't mention it in the talk, but it's a growing, not concern, but it's a subject of much interest nowadays. It could be a sequential combination therapy. It already happens, you know, kids being, for instance, on nusinersen for a while, asking for gene therapy because it's fancy, or just vice versa, kids being on Zolgensma, but parents being so afraid that they want a double insurance and have access to nusinersen or risdiplam. And another type of combination therapy is to give both drugs at the same time, you see. But this is not, I don't think it's ever happened. And it wouldn't be reasonable and not very logical to prescribe, for instance, risdiplam and nusinersen, which are acting on the same target, which is the splicing machinery. But with other drugs coming, perhaps we'll have to consider this combination therapies that way. I don't know what you think, Emmanuel.
One of the things that is always striking for me is that it's we are all thinking globally the same way, but the decisions that are made from one country to the other are really difficult. For example, I was watching a really interesting talk from the German colleague recently. At the time, they are regularly going for gene therapy, but what they have been deciding for a couple of kids, if for practical reason, it took a couple of days more to perform the gene therapy. They are going one nusinersen shots, sometimes one or two. They are not finishing the loading dose, and once they are able to inject the gene therapy, they go for the infusions. So it also depends on the local regulation, local. I don't want to say way of thinking, but that's a bit the reality. And we are all working. Also, the ENMC is working on trying to gather all the way of performing the therapies to at least be logical and avoid people going from one place to the other. There's also the question about putting more nusinersen. There's a trial at the time that is trying to see if giving more than 12 milligrams should be logical. That's the DEVOT trial. So there are many things still happening at the time in the SMA landscape. And I honestly think it will take a couple of years to be clear. I don't think we're going to have the answers in something like 1 or 2 years. I think if I must make a guess, I would say maybe for 5 years it will become clearer. That's why, as Andoni was saying, we need to be honest with the families and telling them what we know, what we don't know. We're beginning to have almost at least a clear view on what is going on when we begin using Arsene, because it's been a couple of years now. But for gene therapy and Risdiplam, we still have a lot of data to accumulate, to be clear.
Okay, the next questions are about, again, comparison of Risdiplam and nusinersen. The question is, has there been any head-to-head study to compare Risdiplam and nusinersen? No.
Not that we know of, no. And that's the problem.
I will say this is, we have been asked by the laboratory, they are planning to do that, but the condition is too difficult. The conditions are too difficult, meaning that the patient who have tried Risdiplam and don't want to have it, and it should be replaced by nusinersen. But the conditions are very difficult. So in France, only one patient can be selected to say that, and we are going to refuse it.
Okay, there is no other question. Most of them are appreciation of the speakers. And the last comment is, as Professor Nafisi said, we have registered 655 patients so far. That's from Dr. Haydari from Markaz.
That's more than in France. That's good.
Yeah, you must publish this, because France has been working for a long time, and you're clearly better than us on the topic. So that's important to let people know about this huge registry that you have.
We only registered 400, or no, perhaps close to 500, but less than the Iranian registry. So excellent.
Okay, is there any comments from colleagues, from professors? No.
No, it's my pleasure. Now we could invite people for the next one that might take place late August, with perhaps a bigger number of speakers and addressing science and research that is extremely active in Iran, as I know, but also in France, and that we could share our experiences.
Thanks a lot again for the invitation, and the talks even they were great. Yeah. Thanks a lot.
Dr. Nafisi, you are mute. Dr. Nafisi, you are mute. No, you should unmute your speaker.
I would like to thank all the speakers. The lectures were wonderful, very informative for me, and I'm sure for the audience. And I also have to thank the participants that have been with us for more than 3 hours. And also, I would like to thank the TUMS for providing the platform to have this webinar at this time. Thank you all.
Okay, I also say goodbye to all participants. We had a 3 hour and 15 minutes non-stop presentation and webinar. I hope that we would have another bigger webinar very soon. And goodbye.
Thank you very much. Goodbye.